Thank you very much for the privilege of presenting our research. We have no disclosures. Our studies aim to look at the learning curve for transanal endoscopic microsurgery, which is a platform for transanally resecting rectal lesions. And specifically, we wanted to look at the impact of mentorship on learning curves. The learning curve is a graphical or statistical representation of the time it takes for a surgeon to become proficient at a new technique. And this has been looked at in a number of different areas in surgery, laparoscopic colorectal surgery, robotic Whipples, TAMIS, but not as much in TEM. We performed a retrospective review of prospectively collected data, with operative time being our primary outcome of interest. This was adjusted by tumor size. We also collected patient and tumor variables as well, and performed a cubic spine analysis comparing the unmentored surgeons who introduced TEM to our hospital with the mentored fellows, and we also use multivariable regression. Our experience at St. Paul's is pretty extensive, with almost 1,000 cases between 2007 and 2020, with about 17% of these cases being a recurrent disease. Again, some of these cases were quite complex, with 5% entry into the peritoneal cavity, about 66% being closed transanally, and about a third of these being cancer. So you can see here the learning curves for the unmentored surgeons, and the learning curve is identified, or the plateau is identified visually. You can see there's a bimodal plateau, with the first plateau being at around 60 cases, and the second plateau being at around 150 cases. And our multivariable regression, 50 cases, again, seem to be the tipping point for change in operative time, with the only statistically significant variable being tumor size. These are the learning curves for mentored fellows. Fellows had about 30 to 40 cases within their clinical year. When you compare their learning curve seems to be significantly shorter compared to the unmentored surgeons at around 25 to 30 cases. So in conclusion, the learning curve for TEM is substantial, perhaps much higher than some of the other studies have reported, at around 60 to 100 cases, with a second plateau occurring at around 150 cases, which likely reflects the increasing complexity of the case mix. Mentorship seems to matter, with fellows having a shorter learning curve than the unmentored surgeons. There are some limitations with any of these learning curve type studies. Choosing the optimal proxy for surgical performance is challenging, and so operative time is what we used. Sample size limitations exist for the fellow specifically, and generalizability may not exist from a dedicated mentored fellowship year compared to proctorships for fully trained surgeons, and the institutional learning curve is difficult to evaluate. I'd be happy to take any questions or comments from the audience.